cancer for coming to 4 decades. But I realized that as we treat cancer, that there is so much that people misunderstand. It's in a way a very simple thing to understand. And what I would like to do today is to help you understand and dispel the myths behind breast cancer. So with this brief introduction, let me start my talk. Right. When we talk about cancer, okay, the first thing that comes to our mind is, I'm having problems. Okay, when we think about cancer, the first thing that happens is people are anxious and they are scared. A lot of patients actually complain of panic attacks. A lot of them think that cancer is a sentence. Can you hear me? Yes?
Yes, doctor.
Yeah. They're worried about disfigurement. They're worried about the pain. They fear that cancer is contagious. And they are very scared of being rejected by society and their own family. And needless to say, with the increasing costs, it is economically very devastating. So the first thing that we hear about in the newspapers on and on is how cancer is increasing very, very rapidly. Here you have a headline which says that burden is going to double in 20 years. It's doubled actually, and that's going to keep on increasing. We also have other headlines like this, that breast cancer is a new threat among urban women. It's very common among younger women, and it's overtaking many other cancers. But the first thing to understand is how common is breast cancer really? Is it increasing? Then we must understand what is cancer and how does breast cancer develop? What are the factors which affect us? What is the role of early diagnosis and what are the treatments we are discussing? And what are the newer developments? So let's ask the first question. How common is breast cancer? Now, there are 3 things that one has to remember: that all of us have a risk of cardiac disease, neurological disease, cancers, the minute we are born. So there is something statistically which we calculate called the lifetime risk of you developing a cancer. And specifically in this instance, what is the lifetime risk of developing breast cancer? Then we have to know in the population, we keep hearing cancer is increasing, cancer is increasing. What do you mean by that? When we talk about incidence, we are looking at the number of people affected with breast cancer per lakh population. And mortality ratio is the same. How many people per lakh population are dying? So when we look at incidence, mortality, and lifetime risk, we know that yes, breast cancer is one of the leading causes of morbidity and mortality in India today. But what is important is the incidence of breast cancer is far less than what we hear from the West. West, the lifetime risk is 1 in 8 or 10, while in India, it's as much as 1 in 25 or 28, depending on which registry data you actually look at. So just think of our population of women, and we only see 162,000 new cancers, breast cancers every year. And half of this number will die every year. That's mortality. So yes, if you look at 83,000 and 1.6 lakhs, yes, it's quite a large number. But overall, if you compare it to the population in India, it's not high. It has become the most common female cancer in cities. And lifetime risk in Mumbai is still 1 in 28, which means risk till the age of 70. But has breast cancer really increased? Let's look at the lifetime risk. If you really look at the lifetime risk of developing breast cancer, it hasn't changed over the last nearly 20 years. It's about 1 in 28 still, which means that our risk of developing cancer, although numbers may increase, has not changed. Let's look at the trends from 64 to 16. And here you see per lakh population, when you're looking at the AR or the annual incidence, that incidence has increased from 17 per lakh, it's gone up to 32. And deaths have also increased, but not the same, 9.6 to 13 per lakh of population. So if you see the change from 17 to 32 and 9 to 13, you see, yes, the incidence that means per lakh population, the number has increased, but mortality has not increased the same. That means there is something we are doing right with treatment of breast cancers today. So the question that we have to ask is, if a lifetime risk is not changing, why is the incidence increasing? Now, incidence depends upon the increase in population at risk, which is reflected by the effect of age and life expectancy. So if you really just look at the numbers at risk, you see that our population has zoomed from, it's about 138 crores now, and was less than half a billion in 1960s. It's nearly 1.5 billion now. So it's nearly trebled. Life expectancy has increased. In life expectancy in 2014 had come up to 67 years. And now in 2019, it's gone up to 69 years. And if you look at it from 1960s, when it was about 40, 45 years to nearly 70 years now, your life expectancy is increased. That means we are getting a more older population as we age. The numbers have increased, and older population, the number of people who are in the ages above 50 and 60 have increased. The other very, very important point for all cancers is, if you look at the age on the x-axis and the numbers on the y-axis, you will see that as we age, the chances of developing any cancer increase. So as we age, all cancer incidences are likely to increase. So more the people in the aged population, the more the incidence of cancers. And these two slides pictures are very, very important. On the left side, you will see the population. And you will, on the right side, you see the incidence of cancer. So here you see that the maximum population is actually a young population below 40. But the maximum incidence of cancer is above 50s and 60s. That means as this pyramid starts going older, you will have a much higher incidence of all cancers, not only breast. This slide shows the distribution of the population and breast cancer. And again, you will see on the left-hand side is the population in Mumbai. And you'll see 65% of our population is less than 40 years. But hardly 10% of our cancers, breast cancers, are seen in less than 40. That means this first dispels the myth that more and more young people are developing breast cancer. It is still a cancer of the aging population above 50. Secondly, we will see a larger number of young people with breast cancers in our country, simply because although the proportions or the percentages are less, the sheer size of the population of the young people is more. So compared to the West, very often, because we and some Eastern countries have a younger population, we see more young cancers. So this slide also shows you the distribution according to age. So here you see that very, very few cancers are seen really in young. Breast cancer is seen in young. It's more or less a middle age and a cancer of the elderly. But when we compare the incidence and mortality with the West, there's a very striking thing you see. Like in the West, you are seeing this. If you look at this, the pattern of all these graphs, you will see that increasing numbers. So India is also seeing some increase in breast cancer. But what is more important is when you look at the West, you see that they're having a drop in their mortality. Unfortunately, we are not seeing this drop in mortality. And that is a thing to be worried about. And why does this happen? It's simply proportional to the stage at which cancer is diagnosed. Here we find in India that more than 50% of our cancers are advanced at diagnosis. We are just about seeing now 50%, which is far better than 30%, which you used to see a few years ago. So more and more cancers are advanced as compared to early or localized disease. And if you treat cancers when they are localized, your results and mortality is far better. So the problem is the rate of breast cancer is not increasing rapidly, but total numbers are increasing. And that's because of increase in population, longevity, changes in lifestyle, economic development. Breast cancer is the commonest cancer in women today in the cities, but our incidence is far less than the West. It increases with age. And because we have a younger population, we are seeing larger numbers in the young, but it's not to say that breast cancer is commonly seen in young people. Unfortunately, the majority are still at an advanced stage at presentation. Hence, treatments are relatively ineffective in improving the cure rates. Hence, mortality is increasing in India, while it is now showing a drop where they're catching it early and treating it more effectively. And one of the reasons that our mortality is still increasing is because there is a lack of awareness and early detection in society at large. So how can we improve the outcome in breast cancer? You pick it up early stage diagnosis, you treat it adequately. When you treat it early and it's in the early stage, your treatments are much less aggressive. You can do conservative surgery. Drug treatments are less toxic. Very often you may be able to avoid chemotherapy. There are less side effects, so less residual short and long-term effects. The treatments are better tolerated. There's a much better cosmetic outcome as far as breast cancer is concerned. And this can actually only be achieved by increasing awareness and early detection in the community. So the next thing to understand is, what is cancer actually? And to understand that, we must know that we are all made up of cells, tons and tons of cells in our body, trillions of cells. These cells then get organized into different tissues. All normal cells have a life cycle. They will grow, they will divide, they'll multiply, they will die. There are certain start signals which tell the cells to start multiplying. There are certain stop signals to tell the cells to stop growing. This is called an internal cellular clock. And when it is affected, the cells turn raw and the stop signals are not listened to. Cells become abnormal, they become immortal and hence continue to grow. And this overgrowth of cells is called cancer. So on the top of this slide, you can see what is normal. The cells will multiply, divide, and die. And on the lower side, you see what's happening in cancer. The genes are basically affected. We know that all cells have genetic material. The genetic material gets damaged, maybe smoking, alcohol, radiation, or for a cause we don't know, chemicals. The cells have multiple mutations. This prevents the cells from dying, and there's uncontrolled growth, which results in cancer. So how does breast cancer particularly develop? We know a few things. We know that in the body, interestingly, there are three subtypes of genes. We can call them as caretaker genes, gatekeeper genes, and landscaping genes. It's a very interesting concept. So caretaker genes are the ones which are taking care of your genome. They constantly repair all the errors which happen. They stabilize the genome. Gatekeeper genes are those which prevent the accumulation of errors. So if something goes wrong, the gatekeepers will prevent that from happening and collecting. And landscaping genes, on the other hand, they do not give a stromal environment which is conducive to development of growth. So this is a very, very important concept, which in your lifestyle can affect these genes. So a normal cell, this is how the cancer develops. A normal cell gets damaged. The damage cannot be repaired. So the abnormalities will accumulate. This results in an abnormal or atypical cell, which then further continues to be de-differentiated or divide, and then results in a cancer cell. And once the cancer cell is formed, they multiply and results in a growth. Now, if you look at the breast, you can see that the breast is composed of a gland and a set of ducts which take the secretions to the nipple. So that's what carries the milk to the nipple. If you take a cross section of the ducts, and the duct is where about 85% of breast cancers arise, they're lined by a normal lining of cell, a single lining of cell. These start multiplying, then they become abnormal or become atypical. Then you get very, very early cancer. It's called cancer in situ. This is a sort of cancer which cannot spread in the body, and if caught at this stage, it's curable. Then you start invading into the body and then becomes frank cancer. There are multiple steps, and this takes a long time to happen in the body. And when you look at it through the microscope, on the left hand at the upper side, you can see what is a normal duct. Then you can see cells which have started multiplying, but these are normal. Then you get what are atypical. They're not completely normal and not cancerous cells. Then these become early cancer, but this cancer is within the lumen of a duct, and hence duct carcinoma in situ, or cancer which cannot spread. And finally, this is on the bottom right is the frankly invasive breast cancer. Now, the body gives us a lot of time to actually detect cancers. By the time the cells multiply to form 1 millimeter, it's been in the body for quite a few years. And from a 1 millimeter cancer to a 1 centimeter, when it becomes something which can be felt by your hand, it's already been in the body for anywhere between 5, 7 to 10 years. So you have a long latent period before you can detect, during which cancer can be detected early. And somewhere along the line, the tumor cells start invading the body. They can access your bloodstream and lymphatics, and that's how it spreads in the body. So spread of breast cancer takes place locally to the lymph nodes in the armpit, which you call axilla, or to other parts of the body, which is the liver, lung, bone, and brain. This is a slide which shows where the breast cancer is spread into the lymph nodes. And here, this is a PET scan, which shows cancer which has gone all over the body, your liver, lungs, bones, everywhere. So what are the risk factors for developing breast cancer? Age, gynecological events or endocrine events like age at menarche, first birth, menopause, whether you've taken hormone replacement therapy, oral contraceptives, breastfeeding, etc. A family history of breast cancer, prior history of some sort of breast disease, and an environment which is more estrogenic. So it's more sensible probably to divide them into factors that can be changed and factors that can't. So factors which you can't change is your race, your age, your personal health history, your family's history, whether you have developed menarche at an early age and a late menopause. These are not really within your control. But factors which can affect development or your risk is your lifestyle. If you avoid obesity, avoid alcohol, smoking, have an early first child and breastfeed more than a year, avoid hormone replacement therapy are some of the factors which you may be able to decrease your risk. You cannot completely do away with risk, but you may be able to minimize. One of the questions very often asked is, how does obesity affect? Well, obesity, what it does is it increases hormone and growth factors in your body. So the environment changes. And this allows or increases the chances of breast cancer, of cancer cells being produced, and then can be stimulated to divide and cause a cancer. So to decrease personal risk of breast cancer, eat sensibly and be healthy within reason, exercise and maintain an adequate BMI, body mass index, breastfeeding, avoid hormone replacement therapy and oral contraceptives, avoid extraneous hormones whenever possible. So the next thing is that we come to is, what are the signs and symptoms of breast cancer? And that's important to be aware of so that you may be able to detect it early. So why should you detect cancer early? It's because you get a much better long-term outcome. Chances of survival increases. The aggressive treatment is far less aggressive. You can avoid disfigurement. Side effects of treatment can be minimized. There are shorter courses of treatment and obviously decreased costs. To detect breast cancer early, you need to be aware. So first thing is to be aware, or we must have a thought process regarding cancers in general, health in general, and breast cancer. The other way is to do a breast self-examination. So examine yourself regularly once a month. Mammography at regular intervals as advised. Usually an ultrasound of the breast is also done at the same time. And a breast MRI is a problem-solving tool to be used in certain cases. So what are the warning signs of breast cancer? I mean, I'm sure most of you know a lump in the breast is the commonest problem. Sometimes you can get a discharge from the nipple. You can get retraction of the nipple, excoriation of the nipple, changes in the skin over the breast, enlargement of the lymph nodes in the armpit. And sometimes people just feel an odd sensation of breast pain, which really is not a sign of cancer, but tends to draw your attention to the breast, and then you examine it and feel a lump, or you undergo an evaluation and you feel a lump. So every breast pain is not associated with cancer, and breast pain is not a sign of cancer, but it may just draw your attention to the breast, following which you evaluate it and find that there is a cancer. This slide really shows the different warning signs: a lump in the breast, a slight retraction nipple areola, retraction of the skin, little bleeding from the nipple, a lump in the armpit, and excoriation of the nipple. These are all the common signs of breast cancer. A very, very important thing to remember is breast self-examination for two reasons. One, of course, when you examine yourself, you may pick up a lump. But breast self-examination done regularly makes you highly aware of your breasts, what they normally feel like. And if there's a change, you may then report to a doctor much earlier. It should be done once a month, a few days after your periods. You should examine the breast and the armpit and use the flat of the hand and slowly move your finger gently around the breast, trying to feel the tissue which is between the skin and the chest wall. If you feel too hard, you will feel the ribs below and think everything is lumpy. If you feel very softly, you may not feel anything. And there are different ways, but a circular motion is one of the best ways. And you look for little lumps or anything else that you worry about, gets you worried. The next step is a mammogram. A mammogram is just an X-ray of the breast. And this is a mammogram which is showing a frank breast cancer. Mammography is considered standard of care. Ultrasound is not good enough to screen, but mammography is considered good enough to screen. That means normal people can undergo regular mammography for detection of abnormalities. It does have drawbacks. It can miss cancer in 10 to 15%. So if someone says mammogram is normal but has a lump, he should still go for a clinical examination. You shouldn't say that, well, my mammogram was normal, I don't need to go to a doctor. It is compromised in certain dense breasts. So young breasts, less than 50 years especially, and in less than 40, mammography is not very good. If they're augmented breasts with silicone prosthesis or scarring due to previous surgery, it can become more difficult. So mammography, as this slide shows, can be false negative in up to 15% of 50% of young women. It's extremely good after the age of 50. But there is a new technique called tomosynthesis. Well, it's not new now, it's around for more than a decade. And this basically is like a CT scan of the breast. And just to show you how effective it is, this is the mammogram. And you can see on this side that you can see one lesion here. There's a question, there's another lesion somewhere here. And when you take tomograms, you can see in slides, one of the slides, you can see this cancer very well in the other slide. So you take multiple slices. And the way to think about a tomogram is if you squeeze a loaf of bread from both sides, that's a conventional mammogram. But if you slice the whole loaf of bread and then look at each slice carefully, that's a tomogram. Ultrasound is another way of looking at the breast. That's the ultrasound which doesn't give you any radiation at all. It's complementary, doesn't replace mammography. It's very user dependent. That means the person doing the ultrasound has to be very, very experienced. It can pick up cancer in 10 to 15% when mammograms are normal. But it is not used for screening. That means you can't just do a mammogram and say, ultrasound and say, well, my breasts are normal. But yes, if a mammogram is normal, that's more useful for screening of normal women. This is just to show an ultrasound showing lesions, and that's how it can pick up cancer. Yet another technique is the contrast enhanced MRI. It's considered the most sensitive modality for detecting breast cancer. However, one of the problems is a lot of people are claustrophobic, and claustrophobic people cannot really undergo this examination. This is just to show how an MRI can pick up something, a breast cancer, which was not seen on a mammogram or on the ultrasound. So should normal asymptomatic women undergo evaluation, and how should you screen for early diagnosis of breast cancer in these women? So breast cancer screening, screening is when you evaluate normal asymptomatic people in the population. So breast cancer screening is recommended for asymptomatic people simply because it is possible to detect cancer early using different technologies. And it is also treatment is very effective and improves the long-term outcome. So if you don't have a system of detecting the cancer early and a system of treating the cancer highly effectively when it's early, screening is not normally done. For breast cancer, both these things are possible. Hence, breast cancer screening is recommended for asymptomatic normal people. In high-risk populations, there are individualized schedules. The reason we screen, as I said, was mammography can help screen women save their lives because they have shown a 30% reduction in mortality from breast cancer since mammography started. And the services screening guidelines today are self-examination from the 20s, breast self-examination monthly, and a clinical breast examination every 3 years for women in the 30s, yearly mammograms beginning at the age of 40, and a clinical examination every 2 years after the age of 40s. In high risk, you would do an MRI and mammogram yearly. And high risk screening, that means a family history, which is suggestive of multiple members having cancer in the family or a mother and a sister having it. High risk screening should start 5 to 10 years earlier than the youngest member in the family who's been affected. So if you have a young member in the family about the age of 40, the screening should start at the age of 30. A little bit just about diagnosis and treatment. There are 3 main steps in treatment of any cancer, not only just breast. One is diagnosis. That means you have to diagnose that this is cancer. And diagnosis is not to say just it's cancer. Nowadays, we will type the cancer and subtype it, which gives us an idea how this cancer is going to behave and how it should be treated. The next step is to stage it. That means, is the cancer only in the local area where it has started, or has it spread all over the body? treatment is dependent upon both the stage of the disease and the subtype of cancer that you've got. So everybody does not get the same treatment. We call this today individualization of therapy. So how do you diagnose breast cancer? Well, you suspect it on their complaints and clinical examination of a patient, or on mammography, ultrasound, and MRI. But it can only be diagnosed and confirmed on tissue examination. That means you need to take out tissue from the breast or cells and see them under the microscope to confirm that's malignancy. This can be done by a fine needle aspiration. Like on the left-hand side, you can see a syringe with a fine needle, where you take out a few cells. But more and more, what we now do is what is called a core biopsy. A thin core of tissue is removed from the breast, and this the pathologist looks under the microscope to diagnose cancer. A very common myth is that cancer will spread if it's fooled around with, or if you needle it, or that the cancer becomes more aggressive. Needless to say, this is incorrect. We have known for years now, and these needle tests have been done for over 30, 40 years. And if there was any truth to this, that the cancer spreads, nobody would be doing it. And mortality rates would have been much higher after these needle biopsies came into routine use. This hasn't happened. So we know that by doing a needle biopsy, cancer doesn't spread, or the cancer doesn't become more aggressive. Moreover, the needle biopsy gives you tissue, which allows you to characterize the disease effectively, and that which will allow you to treat more in a more individualized manner and make the therapy far more effective. So there are different breast cancer types. I already told you about the non-invasive. There is the invasive type, and there are biomarkers we study. So non-invasive is the ductal cancer in situ, as we call it, which cannot spread in the body. The invasive type are mainly ductal and lobulars, depending on whether it comes out from the ducts of the breast or whether it comes out from the lobule or the glands. And in the cancer, we subtype these cancers based on the biomarkers of certain hormone receptors, estrogen and progesterone. We look at another HER2 receptor, and Ki67 is a proliferation marker, tells you how fast these cells are multiplying. So all breast cancers are not the same. We have different subtypes. And these subtypes, as I mentioned, are based on the biomarkers ER, PR, HER2, and Ki67. And we can subtype these into luminal A, luminal B, HER2, triple negative, etc. These subtypes give us an idea about what the prognosis or the behavior of these cells is going to be like, one. And two, it can also give you an idea as to which drugs are going to be effective in these particular cancers. And this allows you to, as we say, individualization of treatment. Once you have diagnosed the cancer, as I said, the next step is staging. Staging is done by a few blood tests, X-rays, and certain scans. This is just a PET scan which scans the whole body, some blood tests which are done. And this is a scan of the brain, which is showing some lesion here. So we use scans and blood tests to determine the stage of the disease. And once we've diagnosed the cancer and staged the disease, the treatment options can be discussed. There are 3 treatments for any cancer. There's surgery, there are drugs, and there's radiation. A simple way to understand is surgery and radiation will act only locally. They have a local effect. They cannot have an effect anywhere in the body. So in breast cancer, a combination of surgery and radiation is used to control the disease in the breast. We use the drugs to control disease in all other parts of the body. All cancers start in an area and then spread. So we use a combination of local treatment, surgery and radiation, and drug treatment to control the disease in the breast as well as the body. So as I said before, local control of the disease in the breast is obtained by surgery and radiation, and systemic or control of disease all over the body is with chemotherapy, some hormone tablets, or what we call special treatments with targeted therapies. So as I said, treatment is stage dependent, and we decide on what type of surgery, radiation, drugs, and another very important component which is often missed out is psychosocial counseling due to the stress. When we come to surgery, surgery is of 2 main types. You can either conserve the breast or you can remove the breast. Mastectomy has been there for nearly 100 years, and breast conservation has been around for at least 40, 50 years now. And what has been learned that breast conservation is fine for small tumors. There is less morbidity, better cosmetic outcome. It is always accompanied with radiation therapy to the rest of the breast and gives exactly the same results as a mastectomy. So it is incorrect to think that a mastectomy is a better operation. However, even in patients who have very small tumors, which can be easily treated with breast conservation, if a patient feels much more comfortable with a mastectomy, then a mastectomy should still be considered. So this slide just gives you an idea of what is the breast conservation and what is a mastectomy. On the left-hand side is breast conservation. Here there's a lump. You make a small cut, take out the lump adequately, take out some nodes on the armpit. It's all stitched, so you have a normal breast left, and you can then radiate the breast and save it. On the other hand, for a mastectomy, you remove the whole breast and you get a scar like this, which you could, of course, reconstruct later on if you wish. There have been advances in surgery. We call it oncoplastic surgery. You can have reconstructive surgery. All these are meant to improve the cosmesis. And we have become less aggressive in our surgery. So the lymph nodes in the armpit, previously we used to do extensive dissections. They've become more and more and more conservative there. We can reconstruct first. An oncoplastic technique utilizes the same breast tissue which is left behind. And on a more major reconstruction, for example, this latissimus dorsi, you take a muscle from the back. You take the muscle from the back and along, usually with another artificial prosthesis inside, you reconstruct the breast. Or you can just use an expander and implant without the prosthesis, where you first put something which makes space on the chest wall and then put in a silicone implant. There are various other ways, free grafts, microvascular techniques also being used for breast reconstruction. Radiation therapy is like X-rays, just more fancy ways of giving radiation. And now we have all these CT guided radiation, which is routinely used. The advantage is that it allows much more accurate radiation to be given. So it spares more and more normal tissue, and surgery and radiation can effectively preserve the breast. We are now going into more and more of giving smaller doses, increased accuracy, with the whole aim of decreasing side effects, decreasing the cost, and decreasing the duration of treatment. You all heard about chemotherapy, and most patients are extremely scared of chemotherapy. The good news is today, by using molecular forecasting and genomic signatures, we have gone into something called personalized precision treatment, where we can use less and less of chemotherapy. And I think in my own practice, chemotherapy utilizations come down to about 50%. And even when we use chemotherapy, we have less toxic drugs. We are using lower dosage. We have better control of toxic effects. We have smarter and smarter drugs coming up. And everyone must have heard about immunotherapy, which is also making its inroads. Unfortunately, all this has increased the cost of therapy. But what has really been the great advance in the last 10, 15 years or 20 years is that we have now started understanding the relative benefits of various treatments in breast cancer. And as data has accumulated from all around the world, and this registry data that we use, all these sort of things have allowed us to collate data from all over the world, increase the number of patients being treated by a particular type of treatment, and understand their effect. So when you want to really understand the effect of chemotherapy, here you have a patient with a very, very early cancer. And the University of Cambridge has come up with an algorithm on the internet where we put in the patient's age, the patient's tumor size, some more characteristics of the tumor. And lo and behold, the computer gives us data. For example, at 10 years following surgery, this patient will actually have only a 2% benefit by adding chemotherapy and 1% benefit of adding chemotherapy and 2% with hormone therapy. But the survival of the patient with only surgery at 10 years from the point of treatment without chemotherapy is 92%. With hormone therapy, it can go to 94%. And if you add chemotherapy, it goes to only 95%. So 1% absolute benefit with chemotherapy. And one must also remember that half to 1%, there can be serious side effects with chemotherapy. On the right-hand side, this data is shown graphically, where you can see the large blue area is the benefit with surgery, and the amount of tiny benefits that you can, incremental tiny benefits you can get with drug treatments in this early cancers. When you look at more advanced tumors, the same graph shows that the relative benefit of chemotherapy and the hormone therapy will increase. And these sort of patients, we would consider giving chemotherapy because it makes a much more substantial difference. And then, lo and behold, this brings to fore that you must diagnose cancer early, because earlier the tumor that's diagnosed, the less chance of you getting chemotherapy. This is why about 50% of patients today do not get chemotherapy as they're picked up early. Moreover, we have gone into the era, as I pointed out earlier, of personalized medicine. we now can do accurate molecular assessments and then tailor the treatment to an individual based on what he or she's got. So there are various tests, and we call these predictive tests. There are certain tests which tells you prognosis. That means how is this cancer likely to behave? And then you have predictive tests. Predictive tests tell you what is the chance likelihood of benefit of, let's say, chemotherapy. The most common test used all over the world is a thing called Oncotype DX, which looks as a pattern of 21 genes and then gives you a score. This is a patient who's had an Oncotype DX low score, so which shows a very, very low chemotherapy benefit. The recurrence score is just 10, and absolute chemotherapy benefit 9 years is less than 1%. This is all based on international studies, and this is very, very strongly validated data. So the patient on the left does not need to consider chemotherapy. On the contrary, the patient on the right side has a high recurrence score of 31. And here the absolute chemotherapy benefit in this particular patient is more than 15%. And this is the type of patient that you would then consider for chemotherapy. So accurate molecular assessment has decreased the utilization of chemotherapy by nearly 50%. A couple of things about hereditary and familial breast cancer, because this is again a very, very hot topic and a very often asked question by patients. The vast majority of cancers are sporadic. That means they just happen in the community without any known cause. Only 5 to 10% actually have a genomic abnormality or a mutation, which is transmitted in the families. And another 10% to 15%, you can have a cluster of patients in a family, but no known obvious genetic abnormality. There are various genes which have been described, but when we talk about breast cancer, we only really study two specific genes, breast cancer 1 and breast cancer 2, BRCA1 and 2 as it's called. They account, as I said, for 5 to 10% of cancer. But what is important is if you do have this mutation, it's something called an autosomal dominant transmission. That means it can affect males and females equally. And it's one of the reasons why less than 1% of males can also develop breast cancer. And the TSG stands for a tumor suppressor gene. That means there are different types of genes. There are oncogenes which cause transformation of the genome into a cancerous one, and tumor suppressor genes which prevent this. So when we are born, we get two copies of a tumor suppressor gene, one for the father, one from the mother. And both of these have to be knocked off before the cell can start becoming cancerous. Now, we have genetic testing, which is easily available in the community. But what is really more important is to understand what is genetic counseling. Let me just take you through this. Genetic counseling helps you and the family understand what is genetics, how it affects the family, and they take a history of about 3 generations. And then they speak to you and discuss and find out whether there's a likelihood that you could have a genetic cancer. Once that counseling is done, then they discuss the various tests which are available in the community, what sort of result you can expect, what are their fallacies, and if you get a positive test, the most importantly, what is the decision you would make? So that's the important. I do not believe that anyone in today's era should undergo genetic testing without having adequate counseling. So when you have a genetic test which comes positive, what are your options? Okay, let's say you have a family history, you opt to undergo the test, you've done the test, and you get a result which is positive. You have 4 options. One is be under regular surveillance. That means regular follow-up with doctors who will do different tests at different intervals. You have an option of removing both the breasts. You have an option of removing both the ovaries, like Angelina Jolie did. Or you could take preventive drugs like tamoxifen or some other drugs for aromatase inhibitors for a period of 5 years. So these are the 4 options. So risk-reducing surgery is extremely popular in the West. I have seen it becoming more popular in India. And it's very important that Angelina Jolie is the person who's always, either she gets kudos for doing this, or she gets a lot of brickbats for doing this double mastectomy and a double oophorectomy. But in any case, she's the lady who actually brought it to the fore. And I saw the change in India, where early on in the early 2000s, hardly anybody discussed breast cancer genome testing or risk-reducing surgery. And now we are finding more and more people who are coming forward. It's not that I'm suggesting that people should have risk-reducing surgery, but it is an option which is out there, and at least people should know about it. One very, very important myth is that when somebody is diagnosed with most cancers, or especially breast cancer, that there is no life after breast cancer. Now, is this true? Nothing could be further from the truth. The only woman who has swum the English Channel 4 times non-stop is a lady, and a breast cancer so-called survivor. I again don't like the word survivor because these, according to me, are normal people once they have been treated. Like this lady demonstrated that she swam the English Channel after a breast cancer treatment 4 times. There's another lady who's climbed Mount Everest, and these are just a couple, but there are many, many people who are doing this. I have a patient like Lynn Joseph who goes to Mount Everest base camp every year. She's been a very close friend of mine for over 10 years, and extremely active and completely normal. And this is what Lynn Joseph had to say. She didn't want the cancer to stop her achieving her dream. Even with cancer, you are the same person, and you should keep living your life and never give up on your dreams and ambition. Finally, just a couple of words about stress, because that's another very, very common question that is asked: what has caused it? And most people are slightly stressful. So is there a relationship in general between cancer and stress, and breast cancer and stress? So there is no clear evidence that any stress can cause cancer. However, experimental data suggests that stress may result in growth of an existing cancer. It can speed up the spread of cancer, and is postulated due to increased secretion of certain chemicals. If you think in terms of holistic medicine, we believe that stress and the general environment in the body can result in cancer development. But can we put a finger on the cause? There is no specific cause that we can say causes that. But there is some interesting psychosocial data. There are 2 types of general psychosocial well-being. One is a hedonic type. That's a person who's involved in self-gratification. While there's a eudaimonic type who gets a deep sense of purpose in life and self-realization. And they have found that depending on the type of personality, there is a different chemical status in the body or a landscape in the body. The hedonic has more of inflammatory gene expression, less antiviral, less antibodies, and the eudaimonic has decreased inflammation, much more better antiviral and antibodies. So that's supposed to be, like I spoke to you about the landscaping genes. It is likely that stress could affect the landscaping genes of the body, making the environment far more conducive to development of not only cancer, any other diseases. To end, just a few things. One is about a decade ago, this was considered new thinking on breast cancer. Everything is now in regular use, giving far better results. We have targeted radiation, just 4 or 5 days of radiation rather than 15, 20 days. We can do molecular forecasting and individualizing of treatment. We have smarter and smarter drugs. We can use radio frequency to ablate tumors, not in so much in the breast, but in the liver and other areas. And breast endoscopy is something that I've been doing for over 15 years now. So to end, you must be aware, breast aware, practice breast self-examination, undertake mammography at judicious intervals to facilitate early detection. We can cure cancer early if detected early. The treatments are far, far less aggressive, and you can have a much better cosmetic outcome. It's really important to know every breast patient will not require chemotherapy in today's era, and nor does she require to lose the breast. It is very, very possible to live a normal life after breast cancer. And most importantly, despite everything, it's important to maintain a positive outlook to life. I just want to end the talk by not breast cancer, but general causes of cancer. Just slightly beyond what I was supposed to speak, but I think there are a few important things. As I said, just very few causes are actually genetic. The vast majority are environmental. 40% are associated with tobacco, 15% with diet and obesity, when another 20% with infections, and some with pollution and radiation. So these environmental things can be modified. Smoking is very well known. This is Vincent van Gogh's famous painting on the left. Even he was aware of what happens with tobacco. Eating tobacco gives a different type of, oral tobacco gives a different type of a cancer as compared to smoking. Infections can cause cervical cancers, stomach cancers, liver cancers, and all can be effectively treated to prevent it. You've got to be careful of your diet, red meat, preserved foods, artificial sweeteners, and betel nut. Obesity we've already been through, and the importance of early detection. That if you actually detect it early, the outcome is far better. Organ function can be maintained, disfigurement can be avoided, much less treatment, much cheaper treatment, and a far better quality of life. And one can screen for only certain cancers, the cervical cancer, the breast cancer, oral cancers. There are various, this is a very famous statement about 7 warning signs of any cancer. If you have a change in your bowel or bladder, a sore anywhere in the body which doesn't heal, if you have unexplained weight loss, bleeding or discharge, thickening or a lump in the breast or anywhere else, indigestion or difficulty in swallowing, especially after the age of 40, any obvious change in a wart or a mole, if it starts bleeding, it starts scaling, things like that, or if you have a nagging cough or hoarseness which doesn't go away. And you can help to be the change against cancer. Spread the word to try and avoid tobacco in all forms. I know that it's not always all or none, so you should decrease it. Have a relatively healthy diet, alcohol in moderation, active lifestyle, regular checkups, maintain hygiene, and treat infections. And you can always support cancer patients with compassion and kindness. You should understand their fears, give them confidence to get on with normal life, and never make them feel unwanted and different. And remember, cancer can be cured if detected early. It's possible to live a normal life after cancer. Important to maintain a positive life and live a meaningful existence. I think I'll end there. Thank you very much.
Would we have a question and answer session, doctor?
Of course, yeah.
If any of the members present here have any queries, they can ask doctor now.
Hello, good afternoon, doctor. I have a question.
Yeah.
So you spoke about hormone replacement therapy.
Yeah.
Now I'm taking Premarin.
Premarin, yeah, it's very common, yes.
Yeah, Premarin and quarter tablet of Meprate.
Yeah.
So my doctor told me that it is pretty harmless. What's your opinion?
Short-term hormone replacement therapy is fine, but long-term hormone replacement therapy in all forms will increase your risk of breast cancer, maybe minor, maybe major. I mean, it's not that nobody has hormone replacement therapy. It's a very, very common therapy all over the world. So you should be aware that yes, that although different types of hormone replacements have different risks, any extraneous hormones will increase long-term risk of breast cancer.
So up to 3 months, she said I should take.
That's
and then
fine.
stop.
3 months is short.
That's fine.
Yeah, we're talking
okay,
about years. We're talking about years of hormone. People have taken 10 years of hormone replacement therapy.
No. This is just a very short term.
That's fine.
So I had started it some time ago, and then I got scared. I stopped it again, and she says, "No, just have some faith, and since I'm taking both the tablets,
short term is no problem, madam."
Okay, all right, okay. That was my major concern and question. And thank you so much. Very, very informative session, really. Thank you.
Thank you. Hi, Rita.
Rita will come in part 2 now.
I saw that X-ray there. Yeah, as soon as I saw that you put up an X-ray with a big lesion that looked exactly like mine, but I'm not a smoker and I had lung cancer.
Well, it's mostly it's environment, largely environment. That we're not going to be able to control to a large extent.
Are there anybody else who wants to ask any questions? It seems all are enriched with the knowledge that they have received. Doctor, there are 2 things we do normally.
Yeah.
On a visit like this, I will come to the important part later on in this session. But first, I would request all present here to please put your cameras on. We'd like to have a photo op with doctors. Yeah.
How do you do that?
I'll do it, doctor. I'm doing it.
Yeah.
We've been doing it for 2 years now. Okay, and there, Violet and Yasmin, Pragnya, Nimi, Dr. Veronica, Prakash, Jennifer, Gracie, Sheila D'Souza, Daryl, all of you, because you will miss this opportunity. You won't get it again. It doesn't happen every day. All right, I'm going to shoot page 1. Murli, put your... Murli is a classmate of mine. I think he's in Bangalore now. He's also a doctor. Murli, where are you? I think he's gone to page 2. Okay, page 1 is almost full. Joyce is there. Joyce, put your video on. We have one very strict rule, doctor. If you don't put your video on, you don't appear on the show again. So, that helps us, because we need to know that we had a full house like this and everybody who benefited. One moment.
Why my video is on?
Yeah, one sec. I'm just no, I didn't get Joyce. Your video is on? You didn't appear.
Yeah.
Acha, now, no, this is another Joyce. We have got 5 Joyces in the group.
Oh.
This is the Joyce from Cochin. Acha. Joyce, did you listen to the program? Or you just put it on and you disappear? You're muted anyway. Okay, I'll take one with Joyce also. 1 minute. Okay. And now I'm 1 minute. I'm just doing page 2 now. Page 2. Dr. Veronica, Nimmi, Jennifer, Gracie, Mahima, N.S. Chavan, Sheila D'Souza. You're missing this opportunity, friends, if you all don't put your videos on. Forget about not coming next time, but you are missing this opportunity. You won't be seeing this doctor every day. All right.
Okay, sorry, I missed that. Yeah.
Yeah. 1 minute. I'm shooting. 1 minute. Okay, I got it. Let me see. 1 minute. All right. All those who have put their videos on. Pearl, your video was not on, so you are not in the frame. Bad luck. Maybe next time. Okay. And now we come to the first part of it. Is when we propose the vote of thanks. And I see no better person than the person who brought the video. And I was actually wondering, I just kept on saying, what happens if she doesn't show up? If she doesn't show up, I'm not able to get connected through. Anyway, she came through, and here she is, Dr. Rita Joseph. So I invite Dr. Rita Joseph to propose the vote of thanks to Dr. Vinay.
Thank you very much for a very, very enlightening session. Actually, when it becomes a scientific meeting for doctors, even we as doctors get flummoxed, we don't understand all the genetics and the genomics and all that. But when it's for a lay public like this, it makes much more sense for us. And we need upgradation as well. We need to be constantly updated about all the latest that's going on in cancer. Thank you very, very much for giving your time for us. We hope to see you again sometime in the future as well.
Hello, Mr. Roy.
Thank you, Rita, for actually introducing me to Roy and giving me the opportunity to address all you and your friends.
And Rita, we are no longer strangers. We are just friends who have not yet met.
Yes, absolutely.
I've not met Rita, but she has helped bring about 3-4 doctors on the platform.
Rita is very, very helpful.
Yeah, very,
very positive person.
That I'm always
very positive, and that's what we like about her.
And don't forget, I was diagnosed stage 4 lung cancer. More than 1.5 years ago.
I know. Cancer touches all of us. I mean, I've come from a cancer family too. So, it's one of those. And as we live longer, all of us are going to have an increased chance, whether we like it or not.
Very
simply. I often say in a joking manner, if nothing gets you, Alzheimer's will.
So with the vote of thanks said, Doctor, we won't take any more of your time now. Maybe it's a busy day for you. We'll end this session.
Yeah, thank you very much. Thanks.
Nobody has any questions, no?
Thank you, Roy, Mr. Roy. Thank you. Actually, I am under fever today.
Okay.
I couldn't come online.
I saw you come late. Yeah.
Yeah, I came late, but today it is a fever.
No, I'll share the YouTube with you.
Thank you so much, doctor. I couldn't attend the session. Actually, I wanted to know much more about the breast cancer as I am undergoing that treatment now. As a doctor has given me the 5 years course, the tablets.
There's a hormonal tablets.
Yes, hormonal tablets. Because I had taken 13 chemos, and after that, due to my elder brother expired, I was psychologically a little bit disturbed. So they didn't give me the radiation. And after that, they were not willing to give me the radiation. So they have put me on these tablets.
Right.
But these tablets are really giving me a pain in my joints and my body.
I think you may be on those tablets called aromatase inhibitors, and in about 20 to 30% of them, some people will develop arthritic changes. So if you are developing those arthritic-like symptoms, you must inform the doctor, and he may be able to put you on the other group of drugs which doesn't cause these problems.
Okay.
One of the first things I usually tell my patients is stop the drug for 10-15 days, see if it makes a difference to your bone pains. If it's making a difference to your bone pain, then this tablet is what is causing it, and then you should change the tablet.
Okay,
But if it doesn't make any difference, then it may not be the tablet which is causing the bone pain, and you must look for the source of cause.
Because he has been given me the tablet since last 4 months now. It has been.
What is the name of the tablet?
Tablet name is I'll just give meko tablet bataiye. And he has given me the calcium, that osteoporosis also, and weekly one
Yes.
tablet.
Those are the standard tablets to maintain your bone health.
And Ferment, just a minute, doctor. I'm sorry. Actually, I'm down with fever today. Please. Quick. It is Fempro.
Fempro.
Yes.
It must be Femara, one of those, but it's basically one of the tablets cause. Just speak to your doctor. Yeah.
Yes, because he has been the ex-director of the Tata, and
Right.
he at the radiation department. So he has suggested these tablets to me, and with that he is giving me these tablets. That is.
No, I think you should just discuss it with him, madam, and he may stop the tablet for a few days.
Okay.
And change the tablet, but just speak to him. Let them know that you're facing the problem.
Yes, because after this tablets only, I'm getting this joints pain, and my both the feet after chemo is not working properly. It is sun ho jata hai na, it is numb, totally numb. I can't keep my feet barefoot down on
those are because of chemotherapy. That's not related to the tablet you're taking, but
yes.
You need to talk to your doctor.
Okay, doctor. Okay.
Yeah.
Yes, sure, doctor. And doctor, I would like to have your contact number also, because
I'll share it with you.
Okay, doctor. Okay, Mr. Roy. Thank you so much. I can't talk much today.
No. Please relax.
Thank you, doctors. Thank you, Mr. Roy. Thank you so much.
Doctor, I have one more question. How long is it safe to take these tablets safely? I mean, without.
With the hormone replacement tablets.
Yeah. Meprit and.
Well, the hormone replacement is being given to you because for a particular reason. So as soon as that gets sorted, that should be fine. Abroad, the reason for hormone replacement was actually to maintain a much better skin appearance, hair appearance, and maintaining your bone health.
That's one of the reasons she gave it to me, right?
So for a short period, it's fine. 3 months, 6 months. I don't think you should take it long term.
Oh, okay. So 3 months, 3.5, 4 months is okay.
3 months to 6 months is fine.
It's fine.
You know, it is better not to take long term. Nobody can predict how these will behave in anybody's body. You may be the one who can take for 5 years and nothing will ever happen, because once you take hormone replacement, it doesn't mean that everyone will have a problem. A small percentage, 2%, 5% will actually have a problem. The rest are not going to have a problem.
So after I take these tablets, I find that my nipples become a little, stiff and little sensitive.
That's because of everything is under control of the hormones. So the hormone profile in the body is changing. But these are things you must speak to the gynac or who has referred you for these tablets.
Thank you. Thank you.
So shall we end the session if there's no more questions?
Thank you very much, Roy. Thank you.
Doctor, the pleasure is all ours. And
Thank
Dr.
you so
Rita,
much for coming.
We've been
A
waiting
million
for
thanks
almost
to
nearly
you.
2 months.
a million thanks to you. Thank you, Dr. Vinay.
Bye-bye and all the best.
Bye.
Bye-bye.
Bye.
Thank you, doctor.
These are for you.
Now all of you can thank Dr. Roy. Huh? Because Dr. Vinay has gone. So I will convey to him.
Dr. Roy, we will meet you soon again.
Yeah, 3
few
o'clock we
hours
have got
time.
our culinary show.
We will thank you. at that
Thanks,
time.
Dr. Roy.
Yeah. Dr. Rita, you have been very kind. God bless you always. And continue the good work of sending
Yes, I will.
doctors.
I will do that.
Yeah. Now I
Very beneficial for all of us. Very beneficial.
yeah.
We tried to get Dr. Patra, Dr. Kaushal Pandey, and
Yeah.
Dr. Mishra,
Yes,
neurosurgeon and 2 cardiac surgeons.
Yes.
Very
Brilliant.
good.
So, today, so much of information we had,
Yes.
The
I
amount
think
of
everybody
knowledge
is
you
best
shared
done.
with us,
Very rich. Very rich.
very
information.
rich knowledge.
Thank you, Dr. Rita. Thank you
You're
so
very
much.
most welcome.
Dr. Rita is the mother of, guess who?
Yeah, I think her daughter also spoke to us.
Yeah,
once,
Dr.
no?
Christina. She's the
Yeah.
proud mother of Dr. Christina. We had a wonderful. How is she? She's in Assam, no?
For the Christina, yes. She's in
Yeah.
Assam. She's in
Ah,
Assam.
she's
She's
gone
in
back
with
to-
the Apollo
She
group
was
in
in
Assam.
Assam when she spoke to us.
Yes.
Yeah, and she's got a scholarship again, fellowship or something. She's got
She's doing a fellowship in with Apollo. She's
Apollo,
consultant with
yeah.
Apollo Hospital in Guwahati.
Guwahati. She's doing that.
She likes the place.
No, she's doing an arthroscopy fellowship with them. Arthroscopy, so she can bring it to other parts of the country.
Okay.
Fantastic. But that's how many? 2 years?
No.
How long she'll be out there?
Probably till the end of this year she'll be there, and then she'll decide what she wants to do.
Okay.
Dr. Roy, Dr.
Yes.
Roy, can I ask you one question?
Please. There are 3 of you asking me simultaneously. I can see
No, I
Fiona.
attended very late. I really missed the session.
Fiona,
Actually.
these are all excuses, yeah. Come on.
No, really.
I was
really,
seeing you
I wanted
lying
to-
down when I sent you the notice saying that, come on.
but then problem was I was about to start the session and then something, my neighbors and all came up.
Now, let the truth come out.
Okay, my question was, right?
Yeah.
If we want, children's guidance, we can get for medical students or something like that. I mean, who are interested in medical or something.
Yeah, we are having
Career
a session.
counseling.
We'll be having a session soon on that. We had it last year, and I'll start those sessions for career counseling.
Yeah. Because my daughter, she'll be going for 12th next year. Yeah, and she's interested in medical field. So we don't know where to go, what to do. So we want a proper guidance.
We are getting professionals for career
Thank you,
counseling.
Mr. Roy. Really.
No, Dr. Roy.
it's a
Doctor, we are
very
talking
big
about medicine now.
Dr. Roy,
Dr. Roy.
Dr. Roy, can you hear me?
Yeah, I can.
Okay, thank you so much. It was very interesting, Dr. Roy. I was here right from the beginning, but I was not sure what I was doing. But anyway, I was very attentive, and thanks so much. God bless you.
We have
and
all
of
our sessions are very educative, very informative.
This talk was about orthopedics.
Breast cancer, clearing the myths one has about breast cancer.
Okay.
Yeah. Anyway, I'll put. Are you part of the group, Fiona?
Yes. I'm feminist.
I'll share the video on the group.
Thank you very much, Mr.
Anybody who came late, went out early.
It's a big help. Hats off to you.
Yeah. No, not me. This today's session and all medical sessions, all the credits goes to the Joseph doctors.
Thank you, Dr. Rita. Thank you very much.
She's our backbone now.
We have Jarvis also over here living in Bakola. He's an ENT surgeon. Could get him to do something.
Jarvis is supposed to come by the end of this fortnight, I think. He'll come. He's also been busy running around here.
Yes, and this Omicron.
3 or 4 sessions, he's been promising. And then when the last date comes, Roy, I have to rush to there. We are all said and done. If you are a male doctor, your boss is your wife at home. She decides where you go. He committed twice and they said, no, my wife said there's a marriage in Goa.
His wife is a doctor too. His wife is a doctor too.
Oh, really?
So, anesthesiologist.
He calls me in the last minute and says, Roy, I'm extremely sorry. I can't do this because my wife has booked tickets to Goa. I said, no problem. Because, anyway, these are free sessions. Nobody pays for anything. He said, okay. And then then second time, something else happened. Now he said he'll do it in February. Let's see.
Sibyl.
Doctor, thank you so much. Yeah.
Were you able to see me?
No.
I was here from the beginning.
Okay. Chalo, I'm ending the session, everybody.
Yes, thank you. Thank you, Doctor.
Bye.
Bye,
Thank you very much.
Hi, Yvonne. I'll see you in 1 hour's time.
No, I remember how he.
3 o'clock,
Roy, thank you very much.
He just.
Right, 3 o'clock,
No.
Yeah, 3 o'clock. 3 o'clock. 3 o'clock is the
What
next
session
show.
is there? What session is there, Roy?
Culinary.
Actually, there's a lot of noise in between because that session is still going on. Sibyl, actually, Roy sent me a message. Yeah, even I was talking to Roy. I was wondering whether it's on or off because I couldn't see.
Anyhow, I'll say bye.